Wednesday. We're almost there, halfway through. Well, good morning. My name is Sarah Thompson. I am here from Community Home Care and Hospice. I've also brought our social worker and volunteer coordinator, Kelsey, with me. I have prepared just a brief overview, Hospice 101, if you will, just to kind of go over a little bit of educate. You can hear me? How's that? Is that better? Yeah. All right. Very good. Correct me because I'm a walker and a talker. So if I get off, you just steer me back over here. Yes, ma'am. So I have just a brief overview, a little bit of education about what exactly is hospice care. We'll talk about what it is, who pays for it, where hospice can be provided, what may qualify someone for the hospice program or service, if you will, and kind of maybe debunk some of the myths and speculations and fears even that are associated with the word. So as I'm talking, please don't hesitate to stop me if you have a question. I'll do my best to try to anticipate what your questions may be and answer them as I go. But of course, stop me. I want it to be interactive. So sometimes we learn more from each other asking questions and getting feedback. So, all right. Well, the hospice care, what it is a service. Hospice is a visiting service that focuses on not only the patient, but the family as a whole. Our hospice philosophy is really to offer dignity and quality of life, pain and symptom management for not only the patient, but for the family. Like I said, hospice is a visiting service, and where we can go is not only to a patient's home, a relative's home, apartment, nursing facility, assisted living facility, you name it. Hospice can go there. It is not a place, although there are places which we call hospice homes that are offered in some communities. Fortunately, here in Wilmington, we do have, there is a hospice house. It is affiliated with a different hospice agency, but that is certainly an option here locally, which can be a benefit. But again, hospice is a visiting service where we come into a patient or family's home or nursing facility to provide end-of-life comfort care to a patient and family. Now you might be wondering what makes up a hospice team. So it is not just a one-size-fits-all. Every patient, every person, every situation is different. However, through the hospice benefit, we do have a group of clinicians and professionals who come in to serve the patient and family. That group is made up of a hospice physician, who would be the hospice medical director on call to the patient, family, and facility, and staff 24 hours a day, 7 days a week. In the event that there is something that is needed, and it's 3 o'clock in the morning on a Saturday, that hospice physician is a phone call away if we're not able to get a hold of the referring or primary care physician. So that's the number one benefit with the hospice physician. In addition to the hospice physician, you've got a registered nurse on call also 24 hours a day, part of the care team. That the nurses do routine weekly, bi-weekly visits to the patient and the family there at the bedside. Upon admission to a hospice service, you get to know, who the registered nurse is coming out to see your loved one on the routine, regular basis. And as we know, as things change and people need more than the once-a-week visits or twice-a-week visits, the hospice agency would increase the frequencies of that nurse's visits to meet the patient's needs. It is not uncommon to have a nurse come visiting daily. Once we see that someone is making a change, making a significant change with their disease progression, or there is a symptom to be managed, pain, agitation, respiration, you name it, anything. If we see that there's a need, or the hospice sees that there's a need, it is not uncommon for the hospice agency to increase the patient to daily visits. So you've got the hospice physician, you've got the registered nurse, not only doing routine visits, but on call 24 hours a day, 7 days a week. In addition to that, we have a licensed social worker that is really a means to support the support system. Our social work team is actually extremely hands-on in facilitating support for the caregivers as well, not just the patient. Hospice focuses on the big picture, not just the patient and family as well. We recognize that caregivers also need support in that process as well. If you're not taking care of yourself, how can you take care of your loved one? That's kind of what we say. Speaking of, and another thing that our social worker does is can help facilitate placement into facility if the patient is home and is requiring a higher level of care, or is no longer suitable to be at home, or even in an unsafe situation. Sometimes that's part of our team effort, is to help that social worker support that caregiver or the patient and family in finding a place for that patient to stay or live. Kelsey's done it many times where we place patients in facilities. So that is just another benefit to the hospice team. So we've got the doctor, the nurse, the social worker. We have also CNAs, nursing assistants, certified nursing assistants, who you may have experience with if you've ever been to or visited or even had a stay in a nursing home. The nurses' aides are really there to help support patients and families with what we call activities of daily living, bathing, dressing, feeding, toileting, things of that nature. Where the hospice agency can provide that to the patient, whether they're in a home or a nursing facility, wherever they're at. That can tend to be a big help for the caregiver, kind of take that burden off of the caregiver as far as bathing and dressing. You might have an aide coming out every Monday, Wednesday, Friday, or every Tuesday, Thursday to be with the patient for an hour, could be 2 hours, just depending on what the patient's needs are. Getting maybe someone a bed bath or in a shower if they're able to and they can tolerate that. Another piece to the hospice team is through our chaplain. Our chaplain offers obviously emotional and spiritual support to not only our patients, but our caregivers and families as well. Our chaplain also generally would do sort of like a dual role and second as our bereavement care coordinator. Now you might not know, but through the hospice benefit, the hospice team follows the family of the patient through the first anniversary of that patient's passing. So again, kind of going back to the hospice philosophy that, hospice is not just for the patient. We treat the big picture and the whole family as one. So that bereavement coordinator, who's generally the chaplain, will do follow-ups and even counseling with the family, spouse, children, loved one, caregiver, you name it, for 13 months. So we try to get those folks beyond the annual passing of their loved one. Another piece to the chaplain and bereavement coordinator's role is that we offer as a team with the chaplain or bereavement coordinator a annual memorial service where the hospice team will get together, invite all of our past patients, family members, caregivers, loved ones to come annually as a memorial and celebrate the lives of the patients who have passed that year. Let's see. In addition to the chaplain, social worker, CNA, nurse, and medical director, we also have a volunteer piece. Kelsey is actually also duals as our volunteer coordinator. Every hospice agency would have a volunteer piece. That's part of the Medicare hospice benefit, where the hospice can help bring in more support, as in companion care to the home or the facility. Things like listening to music or reading to the patient, just visiting, even just offering a companionship can sometimes be a tremendous benefit to an end-of-life hospice patient. Part of our philosophy is that the more hands on deck, the more eyes and ears, the more one-on-one time we can offer patients and families towards the end of life, the better quality of life and experience we can have. Yes, ma'am.
I'm sorry. I must have missed it. I was going to ask who pays for all of it.
Absolutely.
Medicare, not Medicaid. Medicare pays for it.
So Medicaid also pays for that, and I can speak to that. Who pays for hospice care was the question. So hospice is paid for through most commercial insurance plans, and certainly Medicare, Medicaid. It just depends on who the hospice agency has a contract with, unfortunately. Humana, yes, ma'am. Humana does have a hospice benefit. Now, I will say, again, I hate to be ambiguous. It's not a one-size-fits-all. Every agency is different with who they contract with. For us, for example, community home care and hospice, we are able to accept all commercial insurances, Medicaid, Medicare. We're even able to take on patients who do not have insurance. But that is not a blanket statement for every hospice agency. Just know that, and it also varies from state to state. But in general, Medicare pays for hospice at a 100% rate. We can bill Medicaid, Humana, Blue Cross Blue Shield, Aetna. United Healthcare also has a through hospice benefit. What happens is, without getting too technical, when a patient comes onto a hospice service, even if you have a managed care plan or a Medicare replacement plan, when a patient signs onto the hospice benefit, it is reverted back to standard Medicare. That is not something for you to worry about. That will be something for the hospice agency to iron out in the beginning when someone is signing up for or coming on to a hospice program. But essentially, Medicare and Medicaid pays us, a hospice agency, a daily rate. And included in that daily rate is medications, equipment, service time for the nurse, the aide, all of the interdisciplinary team members to come out. So, there should not be any residual, generally there's not any residual expenditure to the patient or family once they have come on to the hospice program. Did that answer your question?
Again, I might have missed it. My mom has dementia. She has Humana, the Medicare, not Medicaid.
That's okay.
Right. I'm trying to see how this can benefit her. Sure. Because like you said, you're here to help the caregiver too.
Absolutely.
All right. She's very high function, like activities, walks around. She talks, I don't know what she's talking about, but she talks and she eats. So,
yep.
In what way, I mean, is that a part of your companionship program? In what way can you help me with it?
Sure. We should definitely talk after this one-on-one for sure to see how we can help. But in that situation, what we would do is likely send either myself or a nurse out to meet with the patient and family and see how we can help. Humana, her payer source is fine for hospice care. There should not be any hang up there as far as cost or coverage for a hospice benefit through her Humana Medicare. Yes, so that's that. You're fine.
I definitely need the help.
Yeah. Let's talk one-on-one after, and I can maybe set something up for you. But that leads me to, oh, sorry, go ahead.
I had an experience they told you they couldn't do nothing else for you yet. It was like 4 years. I was put in hospice, and the social worker and caregiver very, very nice. I know if the family members come over and his son or his bad, you have to be. They gave him private space.
Wonderful.
Everything was said. He was about the house. It was very, the Air Force was very sensitive. And the social worker and a couple of other ladies. Because every couple of other ladies came in here was
oh, yeah. How about that?
It was so
it sounds like you had a good experience. That's awesome.
I know that he was someone, and at the end, his wife gave him shows.
Yeah, yeah. So part of what we do is education with the caregiver and the family to administer medications. When we can educate a loved one or a caregiver of some signs and symptoms and things to look for, and when to administer certain doses of medications. And I'm glad to hear that you had a good hospice experience. That can certainly shape future decisions.
He didn't have a bed per se for him, but he laid in his chair with his chihuahua. That's what he So they locked him in the chair and they rested.
That's wonderful.
But he was very
good. I'm glad to hear that.
That's a good experience.
Good. I just wanted to touch on real quick. How am I on time? Okay. What might qualify a patient for the hospice service? Particular diagnoses that we see as common incoming diagnoses, if you will, are the Alzheimer's dementia. We see a lot of cardiac, heart disease folks, COPD. That would fall kind of under like the respiratory failure branch, if you will. Stroke, coma, cancer, you name it. If there's a general decline, and what I mean by decline is we look at the last 6 months to a year of a patient's life. We look for things such as frequent hospitalizations, unexplained or uncontrolled, undeniable weight loss, frequent infections, pneumonias, UTIs, respiratory infections, things like that may require a doctor's visit or an antibiotic or even a hospitalization. Falls, frequent falls, increase in confusion or decrease in cognitive ability. These are all things that the nurse is going to look for when she comes in to start hospice care on a patient. You know, it's obviously we are coming in to care for folks towards the end of their life, to offer dignity and comfort and compassion and quality of care to meet the patient and family where they're at. There has been in the past a stigma associated with a 6 month or less prognosis for a patient who is entering end of life hospice care. While we do recognize that that is part of the guideline, we also know that that's a guideline, and that's not always a one size fits all. It's not. That's not every patient is the same. We have had folks with us on the hospice program for years at a time. We've had folks with us who have gotten better, and we say they graduated the hospice program. If they need us again, then certainly we can come back in at a later time. And generally that happens. If we do have someone who has improved to where we can no longer care for them and justify that they need us, we give them a graduation party, send them on their way, and they will call us back. That's generally how that works. Yes.
They were very kind to my brother. And before he got to hospice, the doctor told me it was nothing. And that was heartbreaking to him. So when he got to hospice, it was never brought up.
Yeah. Hospice. Absolutely. Hospice is not, it's not giving up. And I think that is part of the misconception with the word. It's just a change in direction and change of focus on life itself. You know, we have folks who are walking and talking and driving just like us. And then we have folks on the other end of the spectrum who are total care bed-bound patients, who might look like a typical hospice patient, but it's not a cookie cutter picture. But we do focus on, you know, dignity, quality of life, and enhancement of life for however long that may be. We have had in the past, and I'm just speaking from my experience with our team, we've had folks who travel still, folks who have milestones. We, in a past hospice team, we've even facilitated things like renewal of vows. You know, it's what can we do to help improve that patient's life for however long the remainder of their life may be. Yes. Yes, absolutely. That's correct. So the question was, can the hospice come into a nursing home? And the answer is yes, absolutely. While that patient would remain under the primary care of the nursing staff, we consider that patient to be living and residing in that nursing home. That is their home. Just that we would treat that just as a home patient. You know, we would be a guest into the facility, the nursing home, and we would be providing supplemental care for the patient with the nursing staff at that facility. When a patient comes on to hospice care, we sit down with the patient and the family, the caregiver, whoever's with the patient, and we create together sort of a treatment plan or a plan of action, if you will. And we try to do that to meet the patient's needs and goals that they have for themselves. Some of the things that is addressed on admission, and Kelsey, correct me if I'm wrong or if I'm missing something, are like advanced directives, living will, you know, what to do if, you know, things like that. We try to encompass the whole picture of care to provide the best quality to meet the patient and family's needs and goals for the patient. And, you know, 9 times out of 10, we are able to do that without much resistance. So let's see. We talked about who makes up the hospice team, what a hospice patient might look like, where we go, who pays for it. I think one thing I forgot to mention is that Medicare, Medicaid, Humana, insurance as a whole pays us to not only provide care, but also we are able to facilitate and get equipment, durable medical equipment is what we call it. Essentially what that fancy word means is medical equipment, hospital bed, walker, wheelchair, oxygen, bedside commode, all of those things that we can kind of set up shop wherever the patient is, whether it's a living room or a nursing home, or an apartment, wherever the patient's at, you know, to provide, to help provide the best quality of life. If a patient's having trouble walking from the bed to the bathroom, why not get them a bedside commode? If it would make things easier on them and reduce the risk of falls, just simple things like that we're paid to do to have facilitated in the home or, you know, wherever the patient's at, to provide a better quality end of life experience. You look like you're going to ask me something.
Yeah. I described to you what my mother does, and she has dementia. Give me an idea of how would you help her? Would you walk her? Would you? I mean,
sure. Yeah, that's a good question.
I mean, go ahead.
Yeah. So for dementia patient, when we come in, we're not looking at things like physical therapy or occupational therapy to regain strength or mobility, or even you know, increase with the activities of daily living. We're really there for comfort and dignity. So it just kind of depends on what her goals are. Insurance, and I can explain what I mean by that. Insurance, there are two sides to insurance. There's a curative treatment route, where we're talking physical therapies, occupational therapies, chemos, radiations, dialysis, wound care, you know, things like that. The goal is to get better and to regain strength. And while that's done well, that's assuming that the patient is well enough as a whole to regain some sense of quality of life. So that's kind of the curative route. On the other branch of that is the palliative comfort route, and that's where a hospice comes in, looking at quality of life, dignity for however long that might be. These are for folks who have met the point in their disease trajectory that there is no longer option for this curative route. And what I mean by that is maybe they've exhausted all of their resources, they've exhausted every treatment option for a cancer that they may have, they've met their potential with their therapies. Therapy says, you know, mom's dementia is so bad, we really don't see any benefit of trying to teach her because there's no carryover. There's many reasons why someone would shift from this treatment curative route over to the comfort palliative route. And that could be specific to 100 different diagnoses. I won't bore you with that. It's just kind of dependent on what the diagnosis is and kind of how the patient is as a whole, big picture. But with that, insurance will not pay for both comfort and treatment at the same time. So really, before a hospice comes in to start care, part of what we do on the front end, before we even set it up to start care, is discuss what are your goals? What are mom's goals for herself, or her dad, or whoever the case may be? Is it to get better and regain strength for, you know, independent living, or are we past that? Are we at the point of, you know, let's meet mom where she's at with her disease progression? We're not going to hasten it or hurry it, but we're gonna meet her where she's at and try to provide the best quality of life and tailor a care plan towards what's best for her.
I know when they told the family that Gary's heart had stopped, Gary would told us all to leave. And I guess we left about an hour when we came back. He was bathed, shaved,
Absolutely.
I thought that was so kind.
Yes. Speaking of that, that brings me to another point. When a patient does pass, the hospice agency will come in and the nurse will pronounce the time of death, give a bath, total bed bath, shave the patient, get the patient dressed, cleaned up, obviously call the funeral home, and we will wait for that funeral home to get there, and family generally. You know, Kelsey, am I missing anything with that piece? Okay. Yes, that is part of what we do, and that kind of takes off alleviates the burden of that for the family. You know, that's a delicate time and a delicate moment. So that is another piece of what the hospice does. I think if there's anything else that I've missed, how long time? I'm sorry? They are. Yeah, I can hand them out. Are there any questions that you have for me?
No, thank you very much.
You're so welcome. Before I finish, I just wanted to mention Kelsey, like I mentioned, is our wonderful, talented social worker, but she also coordinates our volunteer program. If you or anyone you know may have any interest in inquiring about our volunteer program and being a volunteer or a companion, if you will, to any hospice patient, please see Kelsey. She has, she'll be able to provide you some information. It's a beautiful service, and we often see loved ones of our past patients come back to us to volunteer and sit vigil at the bedside with our folks, or try to give, they want to give back because they had such a good experience. But we're always looking volunteers and people to add to our team. So.